Hello everyone. I am back with a new video, and this time is coronary artery disease. We abbreviate it as CAD, C-A-D, and angina. So let's get started. I'm going to be talking to you first about coronary artery disease. And what is coronary artery disease? Well, I can't really start explaining you what coronary artery disease is before telling you what is arteriosclerosis. So, arteriosclerosis is this buildup of fat and plaque that happens in the arteries. It's the main cause of coronary artery disease. And what happens is that whenever, just like this picture, when fat and plaque starts attaching and kind of almost like gluing to the walls of the arteries, it narrows the blood vessel, and also it doesn't allow blood supply and oxygen to travel. And so it could be partially blocked or completely blocked. When we talk about coronary artery disease, is because arteriosclerosis, or this is happening in the arteries of the heart. So it's a blood vessel disorder in the heart or within the heart. Now, this can happen, arteriosclerosis can happen in any artery of your body, right? But we basically say that it's coronary artery disease when we're talking about the arteries of the heart that deliver oxygen and blood supply to the muscle. And that's very important because we need our muscle to be healthy and strong in order to pump blood to the rest of the body. Who's at risk for coronary artery disease? Well, I think this picture says it all. Men, especially Caucasian, white men, are high risk. Men above 45, women above 55, someone that smokes, someone that drinks, someone that is obese, that has a lack of activity or sedentary, someone that has that abdominal area or large waist area like an apple, someone that has very high LDL or the bad cholesterol, and low HDL, which is our good cholesterol. Another risk factors are comorbidities such as hypertension and diabetes, high intake of sodium, and unfortunately, if you have a family history of this disease, okay? How do we diagnose it? So here I have listed the things that we look for to diagnose coronary artery disease. So for example, your physician is going to order a lipid panel. Now within the lipid panel, you have your good cholesterol, your bad cholesterol, your triglycerides, and your total cholesterol. If someone has a low HDL, and men is less than 40 and women is less than 50, or a high LDL above 130, a high triglyceride of 150, or a high total cholesterol above 200, we say that you are at risk and you kind of can diagnose someone with coronary artery disease. Not just based on that, but it's one of those exams that we look for. So what this means is that for someone not to be at a high risk of coronary artery disease, you have to maintain your good cholesterol, right, high. You want to maintain your bad cholesterol low. Same with your triglycerides and your total cholesterol. So a trick that I could give you to memorize it is we want a high good cholesterol, H good, high good cholesterol, and we want a low bad cholesterol. We also look at cardiac enzymes. Cardiac enzymes are like troponin, which tell us that the muscle is kind of suffering and it's missing that oxygen. Another thing is a stress test where the physician puts you in a treadmill. They're monitoring your heart and they see what you do with activity. Because when we go into activity where we are forcing our heart to pump higher and pump more blood, and your arteries are narrow, that's going to hurt. It's going to cause symptoms. And same as a heart catheterization, they visualize those arteries and they can see if they're occluded or if they have plaque and whatnot. And I'll cover some of these a little later. So, can we prevent coronary artery disease? Well, yes, absolutely. And that's the key, to really prevent it and educate our patients and what to do, what not to do before it gets worse. And then they have the problem. We don't want to get to a heart attack, so to speak, before we intervene. So, diet is going to be very important, right? Cholesterol comes from diet, most of it, although it's hereditary as well. But we can lower our saturated fats and cholesterol food, fried food, red meats that are filled with fats. We can increase the consumption of omega 3s, like good fats like salmon, avocado, tuna, flax seeds, and lower our sodium intake. We recommend patients to exercise at least 30 minutes of moderate activity at least 5 days a week. And when I say moderate activity, is something that elevates your heart rate, like walking, cycling, hiking, swimming, not just, yeah, I'm just gonna take a stroll very slow. Monitor your weight. The weight has a lot to do with it, especially that abdominal waist. Monitor your blood pressure. Stop smoking, stop drinking, all those modifiable risk factors. And then, yes, there's a drug therapy that we're going to discuss for worst case scenarios, or also if we're trying to keep it under control. But always remember and always teach that therapy, it's not all, if you want to really minimize the risk of a heart attack, then you need to not only just take your medicines that are there to help you, but also diet, exercise, lose weight, and stop smoking and drinking. So let's talk about the drug therapy. They're called basically cholesterol reducers. There's different classes within the cholesterol reducer class. And so this one are HMG-CO reductase inhibitors. They're commonly known as statins because they finish in statins. So watch this. Atorvastatin, pravastatin, and simvastatin. See how they all finish in statin? So when you hear statin, you think about cholesterol, something that basically reduces cholesterol. These three are actually, all four are very common in patients, and you're going to see them in the hospital. The key thing about statin medications is that you need to monitor the liver enzymes. Those can be affected. They actually go high. They can also cause muscle pain and weakness. And it leads to something called rhabdomyolysis, which is the breakdown of the muscle. And so that causes pain and increases the creatine kinase levels, the CK levels. So you got to monitor those as well. The next mini classification is fibric acid derivatives. If you hear the fabric acid, you're gonna see here a link. Watch some of the medications. It's fenofibrate and gemfrozil. So they have that fiber in the middle. So that's another way of identifying them. You have to also monitor the liver enzymes. They can cause some GI issues like nausea and diarrhea, and they interact with warfarin. Okay, so warfarin is an anticoagulant, and so it can cause more bleeding whenever you are taking a anticoagulant such as warfarin. Also, they can cause hypoglycemia when taken with diabetic drugs. So, for my patients that are diabetics and they take hypoglycemic agents, you have to be careful. And you're going to see that in diabetic patients, most of the times you have a patient that takes a oral hypoglycemic agent with a cholesterol medication. That's not very uncommon to see. Another class is the bile acid sequestrants. These don't really have a specific prefix or suffix or in the middle, but it sounds like cholecystaramine, cholecystazolone. So they all have that choline there. They can have a bad taste, GI upset, heartburn, nausea, pain, constipation, and they need to separate or kind of not take it with other medications for at least 2 hours. So that's something we teach. The let's see, the Welcutch one, it's a very big pill, very white, and it almost looks like a horse pill. So a lot of patients have trouble swallowing that, and you could just divide it. The other one, the cholestyramine, sometimes comes in a powder, and you mix it with something to drink. The next one is cholesterol absorption inhibitors. This one is very common too. Zetia is the brand name. And again, GI upset. And if you notice here, a lot of the liver and also GI upset. And then your omega-3 acids, because we know that we need to increase the good cholesterol so it can eat the bad cholesterol. So that's why omega-3 are also part of the treatment. And omega-3s are like fish oil, okay? All right. The next one is niacin. Although I don't see this very often, really prescribed in the hospital, but you can take it over the counter if you want. Just teach your patients that it is a sort of a vasodilator, so it can cause redness and hypotension. In that redness, you can see them in their neck or face, and some people can develop itching. The next type of medication for coronary artery disease is not really to treat the cholesterol, but is to prevent the complications. So I kind of told you earlier that whenever the blood vessel becomes narrow and it's smaller and smaller, it's difficult for blood to go through it. And so we have platelets that aggregate to that fatty deposit, and they start aggregating and aggregating, and then you have that narrow passage. So your risk here is to get a clot there or just occlude the vessel completely, and then you have a heart attack. So something that we can use as prophylactically to prevent clots is aspirin and clopidogrel, or commonly known as Plavix. There are antiplatelet medications, and they basically inhibit those platelets from sticking to each other. However, if you're preventing platelets from sticking to each other, you're at higher risk for bleeding. So you want to educate the client on what to do and what not to do when you're taking these medications. And I'm just going to mention just a few because this is an overview video, but just like the shaving, falling, not taking other medications that contain aspirin, etc. Okay, like notifying your physician that you're on these meds, especially if you're going to have procedures that involve bleeding. Okay, so that's coronary artery disease. Let's move on into angina. Now, angina, angina is not really a disease, is a symptom that derives from something that is happening in the heart, and it's linked with coronary artery disease. All right, so let's see. So angina, on its Big spectrum is whenever the supply of oxygen and nutrients in the blood is not sufficient. So then your heart, just the muscle itself, hurts. So that's why it's not a disease, it's a symptom. Um, and it could basically be reflected or be shown as a pressure, tightness. Some people say an elephant is in my chest, or heaviness. It can radiate to the shoulder, arms, the neck, the jaw, or the back. So that's why every time someone complains of chest pain, we have to really rule out, is it okay, is it just angina? Like, because maybe they're having some atherosclerosis, the blood vessel is narrow, or are they having a heart attack? And we don't cover heart attack in adult, but I just want you to kind of start thinking of that. Um, when someone has severe arteriosclerosis or they've had a heart attack before, they can experience chronic stable angina. And that's really what we focus on in adult. Is this intermediate chest pain provoked by the high demand of oxygen levels, whether you are physically exercising, you're having stress or an emotional upset. And so therefore the demands of oxygens are high and you get that pain. Um, Pain and dyspnea and epigastric discomfort. Now, we consider MI a heart attack whenever there's complete blockage of blood flow. In angina, you not necessarily have a complete blockage, you're just having a decrease of the oxygen level. And so then your heart hurts. The pain and discomfort from angina usually lasts about 5 minutes or less. It should be intermediate and it should be released once you stop the activity. So, for example, let me give you an example. I'm climbing up the stairs and I'm like, oh my God, short of breath. My chest hurts, but if I stop and sit down, my angina should go away. Okay. Now, if it doesn't go away, then that could mean that we have a complete occlusion, like a heart attack. All right. How do we diagnose heart problems? And this is just in general for the cardiac session. Like, what do we do to really know, is this is a heart attack? Is this angina? Is this a problem with the valves? Like, what do we do? So we have different diagnostic testings, and I list them here. I'll kind of briefly talk about each of them. EKG looks at the electricity of the heart, the electric conduction of the heart. And this basically can tell us if we have dysrhythmias, it can tell us if we have an ischemia. And now the technology is so advanced that we have things that are called implantable cardiac monitors. They basically implant them within the heart there, and it almost looks like a mini not a USB, but what do you call that? Well, I'll show you a picture here shortly, but it's very small, and then your doctor can see your rhythm and any changes on it in a computer or in your cell phone or in a little device. So that's really cool, and that's it's fairly new. Okay, we also have the stress test. Told you the patient gets in a little treadmill and they make them exercise to elevate the heart rate, the demand of oxygen, and then if they have ischemic changes, they should be able to see it in an EKG. An echocardiogram is actually seeing almost like an ultrasound of the structure of the heart inside. And you can see the valves, you can see how it's pumping. I'll show you a picture here too. Cardiac enzymes, I touched them already. We got troponin, which is the big one, and it basically tells us if the muscle is lacking oxygen and it's hurting, um, and having trouble. And then we have coronary angiogram, which looks at the blood flow of the coronary arteries. So here's the little picture of that little, it's kind of like a little USB that basically they put in the heart, implanted, and then your physician and the patient can look at the rhythm. It's called an implantable cardiac monitor. And then here's the difference between an electrocardiogram and an echocardiogram. So the electrical cardiogram is our EKG, what you guys normally see as live. It's a rhythm. Echocardiogram, echo, it's the visualization of the valves, the chambers, atriums and ventricles, and how much blood is pumping out. Okay, and it looks like this, almost like an ultrasound. So that's an overview of just the diagnostic testing. So now that we know, okay, we have angina, then what can we do about it? Well, the goal really focuses on increasing that amount of oxygen to the muscle, because that's the problem. That's why the muscle is hurting. It's hurting because it's narrow, because of arteriosclerosis. You're trying to pump all this blood through it and it doesn't go really anywhere, or very little goes through it. So we need to increase the oxygen supply to the muscle. So we do this by, first of all, trying to identify, manage, and prevent the risk factors, educate about all those modifiable risk factors, trying to eliminate them, like, drinking, smoking, exercise, a better diet, etc. We can give them antiplatelet medications to prevent a complete obstruction, like aspirin and Plavix. We can give them cholesterol reducers that I mentioned earlier in coronary artery disease. That way that plaque doesn't continue to build up and occlude the artery completely. But really here, one of the key medications is nitrates. Nitrates are very potent vasodilators. So we know the problem is that the vessel is narrow. So how about if we dilate the artery, just like this picture is coming here? And I'm going to tell you here shortly about nitrates a little bit more in details. Another thing that we can do for them is something that we call percutaneous transluminant coronary angioplasty, or PTCA, with a stent. They literally go into the artery of the hearts, the arteries in the heart, and they look at them. They can squeeze the plaque out and put a stent. I'll show you here in a little bit. Another thing is coronary artery bypass graft, or commonly known as CABG. On CABG, you're rerouting your arteries, and I will show you in a little bit more. So let's talk about nitrates. So I told you they're very potent vasodilators. It basically relaxes all the smooth muscle, large and small coronary arteries, or any vessel in the body. And so they are used to prevent and treat angina. And these drugs are also used for other things like blood pressure and, like a different type of nitrates. But in particular, we're going to be talking about nitroglycerin. And so nitroglycerin basically relieves that spasm in the coronary artery, comes in different forms like sublingual, spray, ointment that they put in their skin, transdermal, and IV. It also comes in pill form, nitrates, like long acting ones. And you'll see them, they are called isosorbate mononitrates, and the book talks about them in their PO form. So nitroglycerin, they come in this little vials, just like this picture here shows. The little bottle is like brown. The cap is it's metal, and literally they're about this small. They're very tiny pills, but oh my God, do they work? So, pretty much you can take these pills every 5 minutes times 3 doses. It should relieve the pain for about 30 minutes. Um, and if you still have the pain, then you need to call 911 after those 3 doses. You should keep them in the dark. They kind of don't like a light. That's why the bottle is brown, to keep the light from them. And they last about 6 months after opening them. They lose that potency when you open them after 6 months, especially if you don't feel that tingling underneath your tongue when you put them, because these are sublingual. That means they're not potent and you should change them. You should educate the client on the proper technique and rules of taking this medication. You should also advise them not to combine them with any erectile dysfunction medication, because it can cause more vasodilation and syncope or hypotension. Um, you should also tell them to take them before they do an activity that they think that might exert them or require more oxygen delivery. So kind of like at a as needed basis before activities or at the first sign of their angina. Um, Teach them about the side effects like headaches, dizziness, and flushing of the skin because of the vasodilation. And also watch out for orthostatic hypotension. So again, it really relaxes the muscle, can lower the blood pressure, and so we should instruct our clients to raise slowly, kind of sit first, then get up, and then if they don't feel dizzy or whatnot, then move. So that's kind of like a little overview of nitroglycerin. Another thing is, in general, for angina, we need to kind of make sure that the patients take their medication, try to avoid excess fatigue, kind of make those rest periods, help them with LDLs, provide a lot of education on a cardiac diet and what to eat, what not to eat, and prevent the complications, and also allow them to express themselves and their feelings. So a lot of people after a heart attack or an angina or whatnot, they feel kind of scared that it's going to happen again and that they're going to die soon. So encourage them to express their feelings. Here's a picture of the coronary interventions. So percutaneous, kind of like the stent. So pretty much they go into the coronary arteries through either your groin or your radial artery. And they put this very flexible, uh, thin wire. And at the tip, this wire has something that can push against the artery and kind of squeeze the plaque out and put a stent. In a stent, the stent has antiplatelet medication in it, and so it allows to restore the blood flow and make sure that nothing sticks to it. In order to guide it up to the artery that we needed, the physicians use a dye and x-rays. So they'll inject this dye in through the vein and they start taking x-rays. And we do this in cath lab. Um, let's see. Another thing is, of course, this is like an invasive procedure. Although it's minimally invasive, we need to get a consent. We need to advise the clients about complications. So after a procedure like this, patients can have maybe an allergic reaction to a dye. They could have arrhythmias. They could have kidney compromising problems. So because of the dye, it's kind of harsh on the kidney, so they need to flush all that. They can maybe um, cut or puncture one of the arteries. So we need to watch out for that when they come out of the procedure. And so that is why after the procedure, not only are we going through the femoral artery most of the times or the radial, we need to put pressure on that femoral artery or radial artery. If it's femoral, they should stay in bed for hours. Now, with the advances of technology, now they could go from through the radial artery and they just put this kind of cuff that puts pressure. So it's easier for patients. But if they go through the femoral, they stay in bed. We got to monitor their cardiac rhythm because it can cause arrhythmias. So telemetry, EKG, monitor for chest pain. We take vital signs every 30 minutes. And we check the extremity for neurovascular checks every 15 minutes to make sure that there's good circulation. So whether they go through the radial or the femoral, we check the distal part. So in the hand, it will be the fingers, and in the femoral artery would be the toes. Okay. So we look for um, capillary refill, pallor, sensation, pain, and movement. Those are the big ones. Um, let's see what else. And of course, any complication or any changes that is not expected, we report to the physician immediately. Here's kind of how it looks like, the dye with the x-rays. So if you see here with the arrows, you see that that's where the narrowing is happening. And so they can go in with that flexible wire and get in there and push onto the arteriosclerosis and put the stent. The next one is, here's your coronary artery bypass graft or cabbage. And basically the cabbage, what it does is that they're rerouting the arteries. So sometimes there's some arteries that they're so occluded and they're so in a place that the wire can't get to them. And so what they'll do is that they'll reroute it and they'll connect it from where it's not occluded to then another part of the artery that is not occluded, and that's it. And then here's the cuff that I was telling you about, that now they're doing whenever you have this through your radial artery. Okay, here are my references. I get everything from the book or the images from Google. I hope this was helpful as a review, and I'll see you in the next video. Bye-bye.